Hello and welcome to Practical ECG courses. My name is Obaid and I am an emergency physician working in the UK. Like I said in my previous video, there are two ways to interpret ECGs. The first method is pattern recognition, which is the most common method used to interpret ECGs. Basically, it involves recognizing some patterns on the ECG and making a diagnosis based on that. So, what happens with ECGs in which you do not recognize the patterns? This is where deductive analysis comes in. It is the next step in ECG interpretation, wherein you know some basic concepts and then apply those concepts to analyze ECGs. Unlike in pattern recognition, wherein you are looking for a diagnosis, in deductive analysis, you will look at the ECG and try to understand what is happening in the heart. If you want to be really good with ECGs, you need to develop your ECG interpretation skills beyond pattern recognition. This is because pattern recognition works only with diagnostic ECGs, which is a minority of the ECGs seen in the ED. Unfortunately, a significant number of clinicians are not familiar with deductive analysis. I have spoken about deductive analysis in detail in my previous videos. I've also discussed it in detail on my website in the section on learning ECGs. If you want to know more, check out this link www.practicalecgcourses.com/learning-ecgs. I'll leave a link in the description below. Let's crack on with today's ECG then. A 50-year-old man comes to the ED with chest pain, and this is his ECG. Pause the video, have a good look at the ECG, and come to your diagnosis. I hope you have come to a conclusion, and if not, good, because I can show you how to use deductive analysis to interpret unfamiliar ECG patterns. I purposefully select relatively simple ECGs for these videos. Remember, the whole purpose of this video is to demonstrate how concept-based interpretation can be used to analyze ECGs in the ED. As always, use a systematic approach to ECG interpretation. To save time, I will discuss only the significant findings in this ECG. The rate is somewhere around 90. To look at the rhythm, we normally look at P waves in the frontal leads. In a normal sinus rhythm, you would expect that the P waves is positive in all of the frontal leads except AVR, where it is generally negative. However, in this case, you can see that the P wave is positive in 1 and AVL, but in 2, 3, and AVF, it is inverted. And you can see that AVR also has a positive P wave. So what this tells us is that this is not a sinus rhythm. So it is a non-sinus rhythm. So what exactly is causing this rhythm abnormality? We'll come to that later. Moving on to axis. The axis is normal as 1 and AVF is significantly positive. Now let us look at the P wave. P wave should always be looked for in two leads, lead 2 and in V1. I know some people say that V1 is the best lead to look for P wave, but this is not technically correct as it is a very simplistic view of the P wave. Both lead 2 and V1 are equally useful because they are placed in different places around the heart. So they have different perspectives of atrial depolarization and therefore they are giving you different information. So there is no question of one lead being superior to the other. Both of them should be used in tandem to analyze atrial depolarization. Remember what I've said in my previous videos. The more leads you have, the more information you get. I will discuss this in detail some other time. So when we look at lead 2, we see that the P wave is negative and we see that the P wave is positive in V1. Both of this is abnormal. Normally lead 2 should have a positive P wave and V1 normally has a biphasic P wave which is initially positive but has a more significant negative deflection in V1. So we have two abnormalities so far. We have a non-sinus rhythm and now we have an inverted P wave as well. Moving on, the PR interval seems okay. The QRS and the QT interval also seems okay. Coming to the ST segment, there appears to be some ST elevation here in the inferior leads in 2-3 AVF, particularly in 2 and in AVF, and also in V4, V5, V6. To some extent in V2 and in V3, but then V2 and V3 are leads where you would expect some degree of ST elevation. As the ST elevation is restricted to the inferior and the lateral leads, could this be an infralateral MI? Moving on, the T wave and the QRS also looks alright, and there are no special waves as well. There's no delta, no Osborn, or no epsilon wave. To summarize, we have a non-sinus rhythm with inverted P waves and ST elevation in the inferior and lateral leads. Now let's analyze the ECG using detective analysis. What happens with a normal heartbeat? The SA node spontaneously depolarizes, resulting in depolarization of the atria. The impulse then travels down the AV node and the bundle of His into the ventricles, and the ventricles get depolarized. Also remember that when the impulse reaches the AV node, the conduction velocity is slowed down significantly to give enough time for the atria to finish contracting and for the ventricle to get filled. When the impulse then reaches the bundle of His, it then instantaneously travels down the bundle of His into the bundle branches and into the ventricles, resulting in near simultaneous contraction of both ventricles. What you must remember here is that the delay in conduction occurs only at the level of the AV node, nowhere else in the conduction system. What happens if the SA node does not spontaneously depolarize and produce a wave of depolarization? Then one of the subsidiary pacemakers take over and produces an impulse. This could be from the atria, from the junction, or from the ventricles. This is called the concept of protection. It means that even if the primary pacemaker fails, one of the subsidiary pacemakers will take over and start spontaneously depolarizing the heart. There are other aspects to the concept of protection. We will discuss them in detail when I do a talk on arrhythmias. For today's discussion, this is enough. This is a simple concept which we have discussed multiple times previously. As you know, the waves of depolarization or the electrical impulses can also be considered to be vectors. So what is the effect of direction of the vector on an ECG lead? Each ECG lead can be considered to be an eye looking at the heart for vectors. If the ECG lead sees the vector as traveling towards it, it documents a positive deflection. If the ECG lead sees the vector as traveling away from it, it documents a negative deflection. There are six leads placed around the heart in the frontal plane: AVR, AVL, AVF, lead 1, lead 2, and lead 3. It is critically important to know the position of each lead relative to the heart. I have already discussed this in detail in my previous talk on cardiac axis. If you are not familiar with this concept, please watch my talk on cardiac axis, at least from the 5th minute to the 16th minute. You should be able to see a link to that session in the top right corner here. I will also leave a link in the description box below. As you can see here, 2-3 AVF are the inferior leads looking at the inferior surface of the heart. 1 AVL are the high lateral leads looking at the lateral surface of the heart. During a normal sinus rhythm, SA node causes depolarization of the atria and the ventricle to happen in this direction. Now the vectors are seen by lead 2 as coming towards it. So based on the principle that we just discussed in the last slide, as lead 2 sees these vectors coming towards it, it documents positive deflections. At the same time, AVR has a distinct vantage point. It is looking over from the right shoulder from where it sees the same reflection as going away from it. So it records all the vectors as negative reflections. This is the reason why all the reflections in AVR are negative. I hope everyone is clear so far. Like I said, I am building upon concepts I have already discussed in detail in my talk on axis. If you have any difficulty understanding these concepts, please listen to that talk before proceeding further. Let us focus on just the atria. There are three anatomically important structures here. You have the SA node, the atrial myocardial tissue, and the AV junction. The AV junction is a term used to refer to the AV node and the bundle of His together. Remember that the atria is again surrounded by six frontal plane leads: the AVR, AVL, AVF, lead 1, lead 2, and lead 3. Normally, the SA node produces an impulse which travels in this direction until both the atria are depolarized. As all the frontal plane leads except AVR sees the vector of atrial depolarization as traveling towards it, these leads document a positive P on the ECG. At the same time, the AVR sees all these vectors as traveling away from it and therefore documents an inverted P wave. This is the concept behind why we say that the rhythm is sinus when the P wave is positive in all the frontal leads except AVR, because it indicates that the atrial impulse has originated from the sinus node. Now that we know the concepts behind atrial depolarization and how it produces P wave on ECG, let us see if we can apply it to solve our ECG. In our ECG, the P wave was not sinus, meaning it did not arise from the sinus node. Where else could it have originated from? There are two possibilities, either from the atrial tissue or from the AV junction. If you remember our ECG, the P waves were negative in the inferior leads but positive in the lateral leads. For the P waves to be completely negative in the inferior leads should see the depolarization vector as traveling away from it. And for the P waves to be completely positive in the lateral leads, these leads should see the vector as traveling towards it. So what this tells us is that the origin of the impulse has to be from somewhere in this region in the lower part of the atria. So as you can see, there are two possibilities. Either the impulse originated from here, that is in the lower part of the atrial tissue, or from here, that is within the AV junction. So the rhythm is either a low atrial rhythm or a junctional rhythm. These are the two conditions which can produce an inverted P wave. Now how do you determine whether it is a low atrial rhythm or a junctional rhythm? Let us first discuss the low atrial rhythm. Once the impulse leaves the atrial foci and reaches the AV node, it then has to traverse the entire length of the AV node just like a normal sinus rhythm. It traverses very slowly till it reaches into the bundle of His. Now, how is this conduction across the AV node represented on ECG? It is represented as PR interval. So what would you expect to happen to the PR interval in a patient with low atrial rhythm? The PR interval will be normal. This is an important point you need to remember. Now let's discuss what happens in the case of a junctional rhythm. In a junctional rhythm, the foci of impulse origin is already within the AV node, and so it does not have much of a distance to travel through the AV node before it reaches the bundle of His. What this means is that the time taken for conduction across the AV node in a junctional rhythm is much less than normal. And how is this reflected on an ECG? As a short PR interval. So the PR interval can be used to distinguish between low atrial rhythm and a junctional rhythm. If you look at both these complexes, you can see inverted P waves in both of them. So which one of this is low atrial rhythm and which one is the junctional rhythm? If you look at the PR interval here, you can see that it is around 4 millimeters. Remember that the normal PR interval is between 3 to 5 small squares or 120 to 200 milliseconds. So that makes this a low atrial rhythm as it has normal PR interval. Now if you look at the PR interval here, you can see that there is only 2 millimeters or 2 small squares of a PR interval here. This is a short PR interval and that tells you that this is a junctional rhythm. I hope you are now clear with the differential diagnosis of an inverted P wave, which is low atrial rhythm and junctional rhythm, and how to distinguish between the two. That is by using the PR interval and the concepts behind how you determine this. Now, what you need to understand is that this is a simplified version of the concepts required to understand and differentiate the various causes of inverted P waves. This level of knowledge is sufficient for most clinicians working in the ED. There's actually more nuances involved in atrial depolarization, which I have purposefully chosen to omit. There are also other clues which can be used to differentiate between low atrial rhythm and junctional rhythm, but that is a more advanced discussion which we can do some other time if people are interested. The motto of my ECG sessions is to simplify and practicalize complex ECG concepts, and I believe this level is adequate for the vast majority of emergency medicine clinicians. Back to our original ECG, there were three abnormalities: non-sinus rhythm, inverted P waves, and ST elevation in the infralateral leads. Now we know that this is not a sinus rhythm. The QRS is narrow, so it has to be a supraventricular rhythm. The P wave is inverted, which tells you that there are two possibilities: a low atrial rhythm or a junctional rhythm. So look at the PR interval. The PR interval is normal, which tells you that this is a low atrial rhythm. So we have solved two mysteries: the rhythm and the cause of the inverted P waves. Now, why is there an ST elevation in the inferior and the lateral leads? Is there an ischemia? Actually, there is no ischemia on this ECG. So when you have an inverted P wave, it can cause the ST to elevate. This is referred to as the Emery phenomenon. The concept behind this is actually simple, but it involves some stuff which most ED clinicians are not familiar with and will take another 10 minutes to explain. In addition, that knowledge does not serve any other purpose in ECG interpretation. So just remember that there is something called Emery phenomenon in which an inverted P wave can cause an ST elevation, therefore mimicking an ST elevation MI. Once the rhythm goes back to sinus rhythm, the ST segment goes back to the baseline. So why is the ST elevation territorial then in this ECG? This is because the inverted P waves are territorial. I have already explained why the P waves are inverted in the inferior leads but positive in the high lateral leads. In the precordial leads, you can see that V3 to V6 has inverted P waves, and so they also can have ST elevation. And why is this knowledge important for A&E clinicians? This is because if you are not aware of the Emery phenomenon, it can be easily mistaken for a STEMI, especially because of the territorial nature of the ST elevation, and patients can be inappropriately taken for a cath lab. There are plenty of cases documented where patients were taken to the cath lab and found to have clean coronaries. So being aware of the Emery phenomenon helps you rule out one of the STEMI mimics. So how would you evaluate a patient with ST elevation and inverted P waves? As always, consider the ECG in its clinical context. If the patient is low risk for ischemia, he may not need much investigation. However, if the patient is high risk for ischemia, you will need to evaluate thoroughly just to make sure that there is nothing else going on. Remember that patients can have two problems going on simultaneously. So to summarize, this patient has a low atrial rhythm and no ischemia. This is the ECG of a 35-year-old male with chest pain who presented to the ED. As you can see, there are quite prominent inverted P waves in the inferior leads. But what was focused on in the ED was the ST elevation. seen in the inferior leads. So there was concerns of a inferior STEMI, and so the patient was taken to the cath lab and found to have normal coronaries. While coronary angiograms are generally low risk, no procedure is completely safe. If you look at the risk benefit ratio of taking a very low risk patient to the cath lab purely because of an ECG finding, then the risks will likely outweigh the benefits, which is why the knowledge of MRI phenomenon is important to ED clinicians. Before we wind up for today, I would like to clarify a couple of concepts regarding the P waves in junctional rhythms. I'm doing this because I frequently see a lot of clinicians getting confused about the P waves in junctional rhythms. Remember, the P wave in junctional rhythm is always inverted. This is because the impulse originates from the AV junction, which is situated in the lowermost part of the atrium. And so the depolarization occurs from the bottom upwards. So the lead 2 is always going to see the vector as going away from it, and hence you will have inverted P waves in lead 2 as well as in the other inferior leads. In junctional rhythms, the position of the P wave in relation to the QRS depends upon the site of the origin of the ectopic impulse within the AV node. There are three possibilities. If the impulse originates in the proximal most part of the AV node, as seen here, the impulse immediately depolarizes the atria next to it. But it has to traverse almost the entire AV node slowly before the impulse can reach the bundle of His. And therefore, the ventricular depolarization occurs much later. By then, the atrial depolarization is already over. So what happens here is you see an atrial depolarization occurring first and then a ventricular depolarization. So on the ECG, this is reflected as an inverted P wave before the QRS. If the foci of the junctional rhythm is in the distalmost part of the AV node, it has a very short distance into the bundle of His, and once the impulse reaches the bundle of His, it instantaneously results in the depolarization of both the ventricles. This foci also sends an impulse backwards into the atria, but this impulse has to traverse the bulk of the AV node very slowly before it reaches the AV node. Once it leaves the AV node, it results in a depolarization of the atria as well. But by then, the ventricular depolarization is already over. So what happens if the foci is in the distalmost part of the AV node? The ventricular depolarization occurs first and is then followed by the atrial depolarization. On the ECG, this is reflected as a P wave, an inverted P wave, which occurs after the QRS. Now, what if the focus of the junctional rhythm is in the center of the AV node? In this case, it has to travel equal distance on both sides, and therefore the impulse reaches the ends of the AV node almost simultaneously, and as a result, the atrial depolarization and the ventricular depolarization occurs almost simultaneously. And how is this manifested on the ECG? The P wave is seen at the same time as the QRS. Because the P wave is so much smaller than the QRS, it is not visible on the ECG. And therefore, you have junctional rhythms where there are no P waves. So what is the relationship of the P wave to the QRS in junctional rhythms? It can be before the QRS, it can be within the QRS and therefore hidden on the ECG, or it can be after the QRS. So all three are possible. Junctional rhythms can have P waves before or after the QRS or have absolutely no P waves visible on the ECG. Let's recap what we have discussed today. First, we discussed the concept behind why P waves get inverted, how to derive DDs for inverted P waves, and how to differentiate between the DDs. A normal PR interval with an inverted P wave is indicative of low atrial rhythm, whereas if the PR interval is short, it is indicative of a junctional rhythm. Then we discussed Emery phenomenon, inverted P waves causing ST elevation, and how it can be misconstrued for STEMI if you are not aware of the Emery phenomenon. We also discussed why P waves should always be inverted in junctional rhythms. and the three ways in which P waves can be related to the QRS complex. And with that, we are done with today's session. If you have not seen my other video on using deductive analysis to interpret an ECG, you can watch it on the link here in the top right corner. If you find this sort of teaching useful and would like me to do more of these sort of videos, let me know by leaving a comment below. And if there's any particular topic you would like me to cover, please let me know. Let me know that as well. Thank you for listening to my talk. I hope this was useful for you. If so, please like the video, leave a comment and consider subscribing. If you find this style of ECG teaching useful and would like to know more about the free online concept-based ECG teaching that I do regularly, please check out my website at www.practicalecgcourses.com. I will leave all the relevant links in the description below. Bye bye for now.